So welcome back to Pharmacology with Dr. Sokolow, and today we're going to talk about the therapies of blood disorders. The first disorder that I'm going to cover are the anemias, and there are three types of anemia: the microcytic anemia, also called hypochromic, because the level of hemoglobin is lower than normal. Then you have the microcytic anemia, where you have megaloblastic anemia, so the size of the red blood cells is larger. And then you have the normocytic anemia, which is the anemia of chronic disease. So anemia is characterized either by a decrease in the normal number of red blood cells or less than the normal quantity of hemoglobin in the blood. So first, let's talk about microcytic anemia. So in microcytic anemias, the cells are microcytic. So that means the red blood cell size is smaller than normal. And so in order to determine this type of anemia, you have to look at the microscopy of the red blood cells, or also to look at the hemoglobin level, because the hemoglobin level are also low in patient who has microcytic anemia. So what are the cause of microcytic anemia? It results from inadequate intake of iron or excessive blood loss. So it's important to determine the underlying cause in order to treat the anemia. And the treatment is to give oral iron supplement, or for those who cannot tolerate the oral iron supplement or are really low in red blood cell count or hemoglobin level, they need to have IV preparation. The consequence of microcytic anemia can cause behavioral and learning problem, especially in children. So as I said previously, so the cause, it's an imbalance between iron uptake and iron demand. It's most common in women than in men. One of the primary cause is pregnancy, because the body changes, and the need for blood flow for the fetuses is high. And then in infant and early childhood, they also need, in most of the time, they need supplement of iron. Now the milk formulation available over the counter are supplemented with iron, but for women who are breastfeeding, it's recommended to give an iron supplement to their newborn. Another cause is chronic blood loss, or for a woman who has menstrual period or heavy menstrual period, that can be a cause of anemia. So the consequences of iron deficiency is the microcytic anemia and hypochromic, or also known as hypochromic anemia. And so the diagnosis, as I said, you want to look at the size of the red blood cells and also at the level of hemoglobin. So the treatment is to give oral supplement, and the most common one, the one that is available over the counter, are formulation of ferrous sulfate, and usually 150 to 200 milligram daily. It's sufficient to compensate for the iron deficiency. So the ferrous sulfate provides about 20% of the elemental iron and is the least expensive one, while ferrous fumarate provides a little bit more of elemental iron. So as you can see, provide 33%, but it's not as commonly available, and in the pharmacy is a little bit more expensive. Some preparation contain ascorbic acid or vitamin C. The reason is that vitamin C increases the absorption of iron, but the downside, it can also increase the adverse effect. And the most common adverse effect are the GI disturbances, can cause nausea or epigastric pain. It's recommended not to take the supplement with food because food decreases the absorption by 30 to 50%. And then you have to be aware about some drug interaction, namely with tetracycline and antacid that reduce iron absorption. So adverse effects, as I said, the most common one are the GI disturbances. They can also cause staining of the teeth. And what you have to be careful is with poisoning in children, accidental poisoning. You know, kids like to explore, and if they run into the mom's iron supplement and take several tablets, that can cause accidental poison, and it can be fatal. And so this is an emergency condition, and if the mom discover the vial, the empty vial, it's important to go to the ER even before severe symptom. And so the first symptoms, again, are the GI symptom, but this can ultimately turn into liver failure and lethargy. So very important to go to the ER on time. And there is a drug, deferoxamine, that can be used for the treatment of acute iron overdose. Now, there are also some parenteral iron form that are available, and this is iron dextran. This is given to severely deficient patients that are either unable to tolerate or absorb oral iron, or of course in case of extensive chronic blood loss. So what is iron dextran? It's a complex between iron molecule and dextrans, which are polymer of glucose. And so those preparations are given either IV or IM. And it's important to give a test dose before administration of the parenteral preparation, because they can lead to fatal anaphylactic reaction. Now, the second type of anemia is the microcytic anemia, and this is caused by a vitamin B12 deficiency. So vitamin B12 or cyanocobalamin, this is the same name, the same molecule. So B12 is essential for the synthesis of DNA. So you see it convert the inactive form of folic acid into the active form of folate acid, and then folic acid is later used for the DNA synthesis. So in order to be absorbed, vitamin B12 requires the intrinsic factor, and so some people are deficient for the intrinsic factor, and therefore they cannot absorb vitamin B12. The elimination of vitamin B12 takes place very slowly, and it can be found in different foods, particularly in the animal products such as liver and dairy product, and also some food are fortified with vitamin B12. So the deficiency, so the causes of vitamin B12 deficiency, it's some enteritis, celiac disease, or patient who don't have the intrinsic factors. In that case, it's called pernicious anemia, and those patients require lifelong injection of B12 because they cannot absorb B12 from the food. So the consequence of vitamin B12 anemia is megaloblastic anemia, and that can cause neurologic damage. Those neurologic symptoms in severe deficiency can actually be irreversible. So it's very important to treat B12 deficiency again on time before leading to those neurologic symptoms, and then can also cause GI disturbances. So the treatment, again, it's a deficiency, so it can be treated by supplement of B12, either oral or parenteral. So if the patient has the intrinsic factor, they can absorb the B12, and so oral supplement are sufficient. But in the case of absence of intrinsic factor, this has to be given either IM or sub-Q. And so again, if the malabsorption is irreversible, they may need lifelong injection of vitamin B12. Now, folic acid deficiency. So again, this folic acid is required for the synthesis of DNA, similar as vitamin B12. So it's essential for DNA replication, cell division. Folic acid is absorbed in the early segment of the small intestine, and significant amount are excreted daily. The dietary source are fresh green veggies, fruits, yeast, animal protein, but it can also be easily destroyed. So the causes of folic acid deficiency is due to poor diet or malabsorption syndrome such as PRU or celiac disease. And also, pregnant women, it's important to give supplement of folic acid because deficiency in folic acid may lead to neural tube defects. So every pregnant woman receive folic acid supplement during their pregnancy for that reason. So the consequence is megaloblastic anemia, so enlarged size of red blood cells. And it's important to distinguish if this megaloblastic anemia is caused by a vitamin B12 deficiency or folic acid deficiency. So it has to be measured by the blood level of B12 and folic acid, because based on the symptom, it's indistinguishable. The only way you can find out is by measuring the level of either one, so B12 or folic acid. So as I said, it's important to establish a diagnostic and to differentiate if a patient with megaloblastic anemia has a folate deficiency or a B12 deficiency, and you do so by comparing the plasma level. So how do you treat the megaloblastic anemia? B12 deficiency may be masked by folate supplementation if it's caused by a folic acid deficiency. And so that's why you have to distinguish, because B12 deficiency can cause irreversible neurological damage, especially in elderly. So folic acid is combined with B12 to treat the B12 deficiency, and in sufficiently large dose, folate will correct the hematological abnormalities, but not the neurological problem of B12 deficiency. So that's why it's important to diagnosed early whether there is a B12 deficiency in megaloblastic anemia. No, normocytic anemia. So the cause of normocytic anemia is chemotherapy or chronic renal disease, because the hematopoietic growth factors are produced by the kidney. And so patient who has a chronic renal disease will have deficiency in those hematopoietic growth factors. So these growth factors are the hormone that stimulate the proliferation of blood cells by binding to the receptor on the progenitor cell in the bone marrow. The treatment of normocytic anemia is to give erythropoietin, so EPO, or the erythropoietic growth factor. So there are different agents, different erythropoietin stimulating agent, or ESA. You have epoetin and darbepoetin, which is the long-acting form of EPO. So you see the regular form is given 3 times a week versus the darbepoetin is given sub-Q 1 time a week. So again, these are protein drugs, so they cannot be given orally, and so they are given either sub-Q or IV. Mechanism of action of those stimulating agents. So EPO is the glycoprotein hormone that stimulate the production of red blood cells. Is the endogenous form, and as I mentioned in the previous slide, it's produced in the proximal tubule of kidney. So those recombinant forms exert the same effect as or endogenous EPO. Clinical use, they are used for the treatment of chronic disease, anemia of chronic disease, so in cancer patient, for example, or patient who has chronic kidney disease. Now, there are non-clinical use that you may have heard if you are a sport fan. It's the exogenous EPO is used as a performance-enhancing drug. Became famous with the Tour de France, where cyclists and some team were using EPO, and that's how it was discovered that it was a performance-enhancing drug. And as Dr. Strillo mentioned in his introduction, is a doping control officer, and I myself was also a doping control officer and introduced him to the world of anti-doping. And so this is something that is evaluated in the urine of the athlete to see if they are not taking EPO to enhance their performance. Adverse effects of EPO is hypertension, but there is also a black box warning that it increases the risk of death and MI or stroke or other cardiovascular event when it's administered to the target level of 11 grams per deciliter. So for the level of hemoglobin. EPO is started in patient who has an hemoglobin level below 10 grams per deciliter, and then the level of hemoglobin is going to go up. Usually when the level goes up to 12 grams per deciliter, then EPO is withheld. And then you measure if the patient is stable and if the hemoglobin level remain within satisfactory level. If it drops again below 10, then the patient will be put back on EPO. Now, there are other myeloid growth factors such as GM-CSF and GSF. So GM-CSF is the granulocyte macrophage colony stimulating factor, and GCSF is the granulocyte colony stimulating factor. So both increase the production of white cells. And the drug is filgrastim or Neupogen. So this is a recombinant form of GCSF, and so it has the same function as the endogenous CSF, which is to increase the number of white cells. There is also some pegylated form of filgrastim, which is the PEG filgrastim, which has a longer half-life, so you have to give less dose, which is always an advantage, especially in chemo patients who are already suffering with their chemo cycle and etc. So the clinical use is for bone marrow transplant to stimulate the production of white blood cells, and used following chemotherapy to reduce febrile neutropenia. It's also used in HIV patient and in patient who has aplastic anemia. The main adverse effect is bone pain.